What's up, Ninja Nerds? In this video, we're going to talk about antiplatelet medications. This video is brought to you by the Great Courses Plus. It's an on-demand video learning service that's going to help you to further your knowledge and understanding in various different topics. Things that we here at Ninja Nerd Science don't really cover, things like cooking, photography, history. So as a student and as someone who's trying to further my knowledge, I love to use as many resources as possible to help me to be a very good clinician. I think the Great Courses Plus would be a great addition to you guys' repertoire. So if you guys can, go check it out. They have an 11,000 plus video library where you guys can watch videos such as something on the immune system by Dr. Anthony A. Goodman. The Great Courses Plus is offering you a free trial, so go check it out at greatcoursesplus.com/Ninja Nerd Science. Also, if you guys want, we'll have a link in the description box, all right? So let's go ahead and get started. All right, Ninja Nerds, so let's go ahead and talk about these different antiplatelet medications. And in order for us to really know all the different types of antiplatelet medications, it's best to look at them based on their mechanism of action, right? So first thing we have to do before we really get into all these medications is just the most basic overview of hemostasis. If you guys remember, endothelial cells, what was their function generally? They were supposed to release specific chemical substances that keep the blood antithrombotic, right? If you guys remember back from that video, we had molecules like PGI2, molecules like nitric oxide. And if you guys remember, what these little guys were doing is they were basically inactivating the platelet, right? So they were keeping this little dude inactivated so that he doesn't attach to the endothelial lining and cause a clot that we don't want. Well, if someone has, let's say, damage to the blood vessel lining, right, for whatever reason, what's that going to do to the PGI2 and nitric oxide production? It's going to decrease. What's going to happen to the inhibition on the platelet? It's going to be lost. So what's the platelet going to want to do then? It's going to want to attach to the endothelial lining. So let's say that there is damage. And you guys know that whenever there is damage to the endothelial lining, the underlying collagen becomes exposed, this little blue stuff here, right? And what happens is there's a protein that binds within that collagen meshwork. And if you guys look here, you guys should be able to name it out. It's called von Willebrand Factor, right? It's made by the endothelial cells. It can even be made by platelets. What happens is this von Willebrand Factor is like glue to the platelets. The platelets love it. They have a specific protein that allows for them to bind onto that von Willebrand Factor. You know what that little sucker's called? The little pink guy? That is called GP IIb. So these little pink proteins here are called GP IIb proteins, okay? And what these allow for is they allow for this connection between the von Willebrand factor and the platelet. So that's really important. GP IIb is the connection between the von Willebrand factor and the platelet. Now, when the von Willebrand factor binds with the platelet has to let other platelets know to come to this area of where injury is so that they can attach as well. How does it do that? If you guys remember, we have little granules inside of these platelets, different types of granules. We're not going to go into crazy detail. There's alpha granules. They release things like clotting factors and PDGF, which is called platelet-derived growth factor. But the more important one is the delta granule, or the dense granules. And these delta granules, they release multiple different types of substances. For example, they can release three really important ones, okay? Serotonin, which is also kind of written as 5-hydroxytryptamine, 5-HT. There's also another one called ADP. And you can also release calcium, but there is another one that's made by the membranes, and we'll talk about that one in a little bit here, called Thromboxane A2. And if you guys remember from that hemostasis video, these guys are platelet aggregation agents, right? So in other words, they tell other platelets to come stick to this platelet. But how does this platelet stick to this platelet? There's got to be a way, right? Well, look here. You see these little blue guys here? These little blue guys here are called GP. Now hold on to your seats. These guys are long. GP IIb 3A proteins. Okay? So here's a GP IIb 3A protein on this platelet, and here is a GP IIb 3A protein on this platelet. What is this little stuff connecting between them? This little stuff between them is called fibrinogen, right? So it's called fibrinogen. Fibrinogen is going to be like a little glue between these two proteins, and it allows for the platelet plug to be stable. So again, platelet connect to platelet through this GP IIb/IIIa proteins. And again, fibrinogen is like the glue between that. So that's how they stick with one another. How do you trigger their aggregation? These little guys. So we have medications that are so cool that you can block ADP. You can break down Thromboxane A2. And you can block this protein from linking to one another. Let's talk about some of those proteins. So the first one that I want us to talk about is this Thromboxane A2. Now, if you guys remember, I said that the Thromboxane A2 is coming from this platelet. It's not really coming from the granule, it's actually coming from a different type of acid. They call it Arachidonic Acid. Let's do this guy here in purple. So you have this guy here called Arachidonic Acid. We're going to put A here. Arachidonic Acid. Arachidonic acid is actually going to be broken down through a specific enzyme into what's called prostaglandin G2. Then it's metabolized again into prostaglandin H2. Is actually going to be metabolized. So he gets metabolized into two different components here, right? One component we're not super worried about. It's like your PGE2, PGF2, PGD2, and there is another one called PGI2. Those ones we're not super worried about right now. The one that we do care about is called Thromboxane A2. So it's made from arachidonic acid. Where does this arachidonic acid come from? Well, you guys know within this platelet, you have a phospholipid bilayer. That phospholipid bilayer can actually get broken down into different types of fatty acids. They call this an eicosanoid. And that arachidonic acid from the membrane can get converted all the way into Thromboxane A2. Isn't that cool? All right, so what does Thromboxane A2 do? Well, when it binds onto this receptor, this Thromboxane A2 receptor, it can activate multiple different types of intracellular pathways, right? So it has the ability to activate like a GQ pathway, right? So GQ, if you guys remember, will actually shuffle along the membrane and bind onto a specific membrane-bound protein here, which is called phospholipase C. Look at this cute little guy. Here, look at him. Aww. So phospholipase C is actually going to get stimulated by this GQ protein. Now, bound to this phospholipase C, it's going to break down the specific membrane-bound structure here, which is called PIP2. When it breaks down PIP2, it breaks it into two components, right? One is called IP3. The other one is called DAG. This is inositol triphosphate and diacylglycerol. IP3 binds onto this little endoplasmic reticulum-like network and stimulates protein channels to allow for calcium to be shuttled out. And then the calcium will do what? The calcium will then come down here and stimulate these granules and cause these granules to start fusing with the actual cell membrane. Once it fuses with the cell membrane, what happens? It starts to release out these little molecules such as ADP, such as serotonin, such as calcium. And again, you're going to get more metabolism of Thromboxane A2. What's going to happen? That's going to cause more platelet aggregation. At the same time, DAG is also activated. And what can this little guy do? DAG can also activate protein kinases, like protein kinase C. Protein kinase C can then go and regulate this specific protein here, which is that GP IIb/IIIa protein. And what does that allow for? It allows for this protein on this platelet to stick with this protein on this platelet through the fibrinogen glue. That's a beautiful thing, right? So, what do we need to block this whole action? Well, we have a drug, a very commonly utilized drug, that basically inhibits one of the enzymes in this pathway, right? Now watch. You know arachidonic acid, there's a specific enzyme called a cyclooxygenase that's shortened to COX. And there's different isomers. There's a COX-1 and a COX-2, okay? There's a specific drug that can inhibit both isomers, okay? And it's a beautiful drug, a very commonly utilized drug, and it's called aspirin, or acetylsalicylic acid. And what this guy does is, if he inhibits, he irreversibly inhibits this COX enzyme. Let's follow this along. If arachidonic acid can't get broken down to PGG2, it can't get broken down to PGH2, and it can't get broken down to thromboxane A2. If there is decreased thromboxane A2, there's decreased stimulation of the phospholipase C. There's decreased production of IP3, decreased production of DAG, decreased calcium getting released from this little endoplasmic reticulum structure, and decreased degranulation. So decreased degranulation. In other words, if you decrease the degranulation, you decrease the aggregation and activation of other platelets. At the same time, you decrease protein kinase C, and you inhibit, okay, there's no more stimulation, so there's inhibition now. And now this GP IIb/IIIa protein on this platelet won't interact with the GP IIb/IIIa protein on the other platelet. So there's no stabilization of that clot or that platelet plug. That's a beautiful mechanism. Love that. So darn cool. Okay, so we got one. One of the big ones here is thromboxane A2. What about the ADP? How does that one important? Let's go over here. So ADP, what does this little guy do? So he comes over here, right? You know, you have a little protein here. There's actually a very beautiful receptor. Here, let's write this receptor's name. This receptor is called the P2Y12 receptor. They call this a P2Y12 that ADP binds onto. So what happens is ADP gets released, right? It binds onto this receptor. Now this receptor can go two different ways. We're going to quickly fly through the pathway. One of the proteins that it activates is called a G inhibitory protein. That G inhibitory protein is going to do a couple different things. It's going to move along the actual cell membrane, and it's going to inhibit this enzyme, right? What is this enzyme here called? It's called adenylate cyclase. Adenylate cyclase function is designed to be able to take ATP and convert it into cyclic AMP. And then cyclic AMP will activate a specific enzyme called protein kinase A. Protein kinase A will then phosphorylate another enzyme. Let's think of a really beautiful color for this one. Ooh. Here's another one. This is called vasodilator stimulatory protein, VASP. Okay? Now, what happens is VASP is going to get phosphorylated into what's called VASP-P, right? So it's going to get its phosphorylation there. Here's what's really interesting. With VASP, whenever it has that phosphorus group bound to it, it's interestingly inactive. And when it doesn't have that, it is active. Here's what's really interesting. What did we say ADP does? It stimulates, let's follow the whole process here. It stimulates the G inhibitory protein, which inhibits adenylate cyclase. That means there's less ATP converted into cyclic AMP. There's less protein kinase A, and there's less of this VASP-P being formed. Okay? When this is active, what does it do? It stimulates the GP IIb/IIIa. Follow that? G inhibitory protein, less cyclic AMP, less protein kinase A, less phosphorylation of the VASP into VASP-P. If this is active, it's going to stimulate this protein. Now we just need a drug that can block that receptor and have the opposite effect, an antagonistic effect. What are some of those drugs? I'm glad you asked, guys. So some of these drugs are called Clopidogrel. It's a very commonly utilized one. Brand name is also called Plavix. Okay, there's another one called Prasugrel, which is called Effient. There's another one called Ticagrelor, which is called Brilinta. And there's another one that's not commonly used as much anymore because of some of the problems it has, developed, such as TTP, and we'll talk a little bit about that in ADRs. But these drugs are basically inhibiting this receptor. So if they inhibit this receptor, what does that mean? That means that there's less G inhibitory protein. that means that there's less inhibition of adenylate cyclase. So that means that instead of having decreased ATP, there's actually a slight increase in ATP. That means that a little bit more ATP is converted into cyclic AMP. That means you get a little bit more protein kinase A. If there's a little bit more protein kinase A, then more of this reaction is heading towards this direction. And there's actually going to be more of this VASP and less of the VASP. So now this is not going to be able to stimulate this anymore. So what does that mean? There's no stimulation. If there's no stimulation, then it's going to start to become inhibited. And what does that mean? That means that the GP2B3A protein of this platelet can't bind to the GP2B3A protein of the other platelet. It's a beautiful mechanism, right? There's also another thing that you will just briefly talk about here, is that the G inhibitory protein is one of the pathways, but this ADP receptor pathway can also activate another kind of like structure here. And what is it? It can also activate GQ. And if you guys remember, GQ will stimulate a specific enzyme called phospholipase C. Phospholipase C does what? It breaks down PIP2 into IP3 and DAG. IP3 does what? It binds onto these receptors and triggers the release of calcium. And calcium will then try to cause degranulation and cause platelet aggregation. And DAG, again, we know that this will activate protein kinase C, and protein kinase C will also regulate the activity of the GP2B3A. So, if you give Clopidogrel, Prasugrel, Ticagrelor, Ticlopidine, what's it going to do? It's going to inhibit GQ, right? If you inhibit GQ, you get less IP3, less calcium, less degranulation, less aggregation, and platelet activation. If you get less DAG, you get less phosphorylation of the GP2B3A, which means less interaction between platelets. Oh, it's a beautiful mechanism, right? So we have aspirin, we have Clopidogrel, Prasugrel, Ticagrelor, Ticlopidine. What else do we have? What if we had something that directly bound and blocked these guys? We do. We do, guys. So what are these drugs that inhibit these? They're GP2BA3A inhibitors. So things like Abciximab, Tirofiban, and Eptifibatide. Okay? Now, these guys will do what? They will inhibit the GP2B3A interaction. If there is no interaction between the GP2B3A proteins, what's going to happen? Less platelet interaction and less stabilization of the clot. That is a beautiful mechanism. So, you have your GP2B3A inhibitors, you have your ADP receptor inhibitors, you have your cyclooxygenase inhibitor like aspirin. There's actually one more. Remember this, we haven't talked about this little dude yet, this little Jerry curl-like enzyme. And this enzyme is called PDE, okay, phosphodiesterase. It's actually it's a type 3 if we really want to be specific. So it's called phosphodiesterase 3. There is drugs that are utilized to inhibit that enzyme. And what are some of these drugs? Well, you have a drug which is called cilostazol. Okay, we're going to put them over here, and we'll bring an arrow to them. Okay, so you have another drug called cilostazol and dipyridamole. And what these drugs can do is they have the ability to inhibit this enzyme. Okay? Now, let's explain why that's important. What does phosphodiesterases do? They break down cyclic AMP. And whenever cyclic AMP is broken down, can it get converted into protein? Can it activate protein kinase A? No. So if you inhibit this enzyme, you inhibit the breakdown of cyclic AMP. If you inhibit the breakdown of cyclic AMP, what does that mean? You get increased cyclic AMP, which means you get increased protein kinase A, which means you get increased phosphorylation of VASP, which means that this is no longer going to be able to stimulate this protein. And so now it's going to be extremely inhibited. So there's going to be extra inhibition. That's so darn cool. So that's one of the mechanisms of these guys. So they have the ability to inhibit this guy. They can also through other mechanisms, inhibit these degranulation as well. But one of the big things is they inhibit this GP IIb/3a. All right, so the last thing I want to talk about was cilostazol and dipyridamole, which is a really cool action of them, and that's why they have another indication that we'll talk about a little bit afterwards, called peripheral artery disease, is they can also cause smooth muscle relaxation. And in blood vessels, that's really important because it can dilate the blood vessel and increase the blood flow around any type of maybe plaque or even thrombi. So that's what's really cool about this drug. So go ahead and take a look at how they actually do that. So if you remember, we have the endothelial lining here, right? And just underneath it, you're gonna have that tunica media. So if you guys remember your anatomy, you have tunica interna, which is basically simple squamous epithelial tissue with a little bit of loose areolar connective tissue underneath it. Then you have, if you really want to be specific, an internal elastic lamina after that. Then you have your tunica media, which is a smooth muscle layer, right? What happens is cilostazol and dipyridamole, what did I tell you they do? They inhibit this little jerry curled like Pac-Man. And again, that is what's really important because this is a PDE3 inhibitor, right? And this is a PDE3 enzyme. So if you take cilostazol and dipyridamole and again inhibit this enzyme, that's important. So how does that work? Basically, if you guys remember, another thing for these, particularly dipyridamole, is you have another molecule called adenosine. And adenosine can actually bind onto these receptors. They can activate a G protein, like G stimulatory protein, which will then activate adenylate cyclase. Adenylate cyclase, when it's stimulated, again, we know that it takes ATP and converts it into cyclic AMP. And cyclic AMP then activates protein kinase A. Protein kinase A then acts on what's called myosin light chain kinase. And what's interesting is that whenever you take myosin light chain kinase and phosphorylate it, it's actually inhibited. So in the phosphorylated form, it's inhibited. And so it's actually not going to be able to do what? It's not going to be able to cause smooth muscle contraction. So if we give a drug, okay, like cilostazol or dipyridamole, it's going to inhibit PDE3. That means that this enzyme is no longer going to be able to break down the cyclic AMP, right? So that's gone. So cyclic AMP production will start to rise. Protein kinase A production will start to rise. Increased phosphorylation of myosin light chain kinase will increase. And now the ability to cause smooth muscle contraction is inhibited. So now what happens to this cross-bridge formation? There's not going to be any phosphorylation of myosin. There's not going to be any cocking and pulling or any of those reactions. So because of that, you get smooth muscle relaxation. Isn't that cool? And if the smooth muscle relaxes, what happens to the blood vessel? It dilates. So these kind of have like a little dual function. They can inhibit platelet activation and aggregation, as well as causing smooth muscle dilation. So that is one of the beautiful things about these medications. So there's a couple of groups of medications that I want you guys to remember. Big one, aspirin. This is a really, really important one, okay? Second group is your antiplatelet medications, particularly they call these thionopyridine derivatives, okay? Don't worry about that. I just want you to remember Clopidogrel, Prasugrel, Ticagrelor, diclopidine, okay? Those are your ADP receptor inhibitors. Your GP IIb/3a inhibitors is Abciximab, Tirofiban, and Eptifibatide. And the last one that I want you to remember, which is your PDE3 inhibitors, which helps to inhibit platelet activation, as well as cause smooth muscle relaxation via vasodilation, is cilostazol and dipyridamole. Okay, so we covered their mechanism of action. We covered what groups they're in. Now let's talk about what we use them for. All right, guys, so now that we've talked about the mechanism of action and how it's basically designed to inhibit clot formation, that's one of the big things, is that it's thromboembolic, basically anti-thromboembolic, okay? So we're trying to be able to prevent that. So what are some different thromboembolic conditions that we have to protect these people from? And that's why they should go on these medications. Well, One of the big ones that you guys gotta remember is acute coronary syndrome. Now, if you guys remember, acute coronary syndrome, we can actually break down into 3 components, right? So we call it acute coronary syndrome, or ACS. We have unstable angina, we have NSTEMI, and we have STEMI, okay? So unstable angina, NSTEMI, which is your non-ST segment elevation myocardial infarction, and STEMI, which is your ST segment elevation myocardial infarction. These medications are commonly utilized in ACS, but more particularly a combo. Usually you're giving something like aspirin plus something like maybe Clopidogrel or Prasugrel, or you're giving something like Ticagrelor. And in rare situations, you might use something like a GP IIb/IIIa inhibitor, specifically like Abciximab, okay? But really the only time where you're really gonna wanna use this one is if the patient is extremely high risk. So what do I mean? You might use this if the patient's like greater than 75. So like, okay, well here, we'll write down a couple reasons. If they're greater than 75, if they're a diabetic, if you see ST segment changes, so ST segment deviations on the EKG, if you see really high trope levels, if they have, if you do an echo and their left ventricular ejection fraction is like less than 40%, or if they have a lot of pulmonary edema, okay? Then that would be reasons of why you want to use Abciximab. The reason why you don't give Abciximab commonly for people who are going to be getting PCI because they have an acute MI is because it has a very high bleeding risk. Okay, you got to remember that. The GP IIb/IIIa inhibitors have the highest bleeding risk. Next thing, how would I determine which one to use between Clopidogrel, Prasugrel, and Ticagrelor? All right, so with utilizing these medications and knowing which combinations to give to these patients whenever they're having an acute coronary syndrome, it comes with kind of learning about the clinical scenario. So, and also their bleeding risk. You got to remember their level of potency, okay? So when we talk about these, starting with the most potent at 1, Abciximab is extremely potent, has a high bleeding risk, okay? So all of your GP IIb/IIIa inhibitors are going to be extremely potent, the most potent. The second one is going to be, out of these, Prasugrel. So it actually has a black box warning, and you got to be careful because of its bleeding risk. After that, you have Ticagrelor, and then after that, you have Clopidogrel. And some will even say that these are pretty much equal in that ability. But then the last one here, which has the least amount of bleeding risk, is aspirin. So we have to realize here, when we're talking about potency, if you have someone who has acute coronary syndrome, they're not extremely complicated. In other words, they're not greater than 75. They're not a diabetic. They don't have chest pain that's been lasting for more than 20 minutes. They don't have any ST segment deviations. Their tropes aren't super elevated. Their left ventricular ejection fraction isn't super low. They don't have any pulmonary edema. You don't really need to give Abciximab, okay? Well, then what about the other ones? Prasugrel, again, you got to be careful. Whenever you're giving this medication, it has a high bleeding risk. So you're going to want to chance that. No. So we won't really do that one unless we absolutely need to. It comes down to really Clopidogrel and Ticagrelor. These are the more commonly utilized ones, okay? Ticagrelor is a little bit more effective and more utilized a little bit more just because there is the risk with Clopidogrel of what's called TTP. We'll talk about that. Also, with Clopidogrel, another thing you have to be careful of is that there is certain individuals who are poor metabolizers. So they have what's called a CYP2C19 mutation. They're poor metabolizers of Clopidogrel. And in those situations, Prasugrel or Ticagrelor would be the more likely option. So ACS is going to be one indication, and it's usually a combo. What else? Well, so again, if someone has an acute coronary syndrome, any of these things, so any blockage, so if they're having any type of thrombus, which is occluding the myocardium, this is going to be a good drugs to give. Another thing that we want to remember is that these are usually medications that you can give pre and post ACS. So you can give these medications both pre, so we talk about giving these medications pre-PCI. So in other words, before they go to the cath lab and they get angioplasty, they balloon up the vessel. and they're good post-PCI. Okay? And again, it's usually a combo of aspirin and something else. More likely than not, it's aspirin and clopidogrel long-term, aspirin and ticagrelor for the pre-PCI. And in super needed situation, aspirin and abciximab if needed pre-PCI. But usually post-PCI, aspirin, clopidogrel. Okay, what about some type of CVA? So certain situations where there's actually blood clots that are actually going to be going to different types of structures within the brain. That could be another indication for giving this. So again, remember that cerebrovascular accidents, this is also a good combo to give. Things like aspirin and things like clopidogrel. Another important thing here with CVAs is sometimes if someone is getting a stent in the carotid artery, so another thing to remember about is if someone's getting what's called carotid artery stenting, you can actually give aspirin and clopidogrel. You can give it pre and sometimes even post carotid artery stenosis, okay? So it helps with that process. So if someone has a CVA or post-CVA, aspirin and clopidogrel are good combinations to give. If someone's getting carotid artery stenting, where they're putting a little stent into the carotid artery, it's also good to have these antithrombotic agents as well. Okay? Another thing is if someone has already had an MI, right? Let's say that they have already had an MI, they have heart failure, something of that nature, right? There's also some risk sometimes. So sometimes if someone has already been diagnosed with coronary artery disease, okay, so if someone has already been diagnosed with coronary artery disease, it's been shown that aspirin has the ability to reduce the significance of any other comorbidity. So aspirin is also a really good indication for individuals with chronic coronary artery disease, and it's just a good prophylactic treatment. So prophylaxis. So basically preventing them from having another myocardial infarction or another CVA, okay? Another really interesting indication for these medications, specifically aspirin, is in certain individuals who get what's called giant cell arteritis. You know there's a vessel here called the temporal artery, and what happens is the temporal artery, it gives off some different branches. So you have the temporal artery, which can actually supply parts of the forehead, right? The temples. But it also has these branches off the internal carotid artery called the ophthalmic artery. And you also have vessels that are going to the muscles of mastication. In certain situations, people with giant cell arteritis, they have inflammation of those vessels. They call it a vasculitis. And you got to remember that vasculitis is a risk factor for developing clots. And sometimes it can cause clots that develop within the ophthalmic artery or clots that develop within the vessels going to the mouth, right, to the jaw muscles. And this can cause jaw claudication. It can cause even possible vision loss and a lot of pain on the temporal region. So a good medication that they give to individuals to prevent them from actually, having some of these symptoms is aspirin. So aspirin is another good medication that's utilized for patients with giant cell arteritis. So we have acute coronary syndrome whenever someone's having an MI and they're going to PCI, post-PCI. We talked about that. CVA, same thing. Aspirin, clopidogrel. One thing you got to remember. When? Because we don't give, if people are having a stroke within the first 3 to 4.5 hours, we don't give aspirin and clopidogrel. It's after that time. What do you give generally before the 3 to 4.5 hours? You give TPA. So you got to remember that this, for the CVA stuff, it's actually particularly when it's greater than 3 to 4.5 hours. Okay? That's when you're really actually giving someone aspirin and clopidogrel combination. So I want to make sure that we're perfectly clear on that. Okay? Giant cell arteritis, again, we talked about its indication, and if someone has diagnosis of coronary artery disease, and it's a chronic condition, you give them this aspirin to prophylactically prevent them from having another heart attack or having any other type of cardiac event. Okay? Another indication. Sometimes aspirin and clopidogrel can be used for PAD, but remember, there was a nice drug we talked about. Remember with PAD, you have vessels here that run through the legs, right? Okay? And sometimes what can happen is they can actually develop plaques or thrombi, or maybe different types of clots that can develop within these vessels, and that occludes the blood flow to the surrounding tissues, such as the muscles and to the feet. What can happen as a result of that? You can get ulcers around that area of the body. You can start getting a lot of what? Maybe even gangrene, okay, because you're not getting enough oxygen and nutrients to the tissues, and so they start dying. What else? The muscles need oxygen in order to contract, so you can get tightness and pain within those muscles. They call that claudication. So this is common symptoms of someone who is struggling with what's called peripheral artery disease, or PAD, peripheral artery disease. When we give medications, we can give medications like aspirin. So aspirin is a good medication to give to someone with peripheral artery disease. But what else is another medication that we can give, guys? We already talked about it. Cilostazol, dipyridamol, so cilostazol. Cilostazol is going to be a big one. Okay, that is the more commonly utilized one. So cilostazol and aspirin are good medications to give to patients with peripheral artery disease. Beautiful thing, right? What's super interesting, and I found extremely interesting when I was actually doing some research, is that aspirin has a prophylactic protection from colorectal cancer. So whenever you're giving somebody aspirin, they've shown that this can actually decrease the risk of colorectal cancer, particularly a type of colorectal cancer called Lynch syndrome. And if you guys know a little bit about Lynch syndrome, it's basically a tumor that can actually form within multiple areas of the body, like colorectal, endometrial, ovarian, renal, pancreatic. So a lot of different things can happen with this. And there's very different variants like Turco syndrome and Gardner syndrome. So again, they've shown that aspirin has the ability to decrease the risk of colorectal cancer significantly. Okay, the last thing that I'm going to talk about, we're not going to go into a ton of detail on it, but dipyridamol. Remember I told you that it causes vasodilation, right? They use it as a specific test. So in people who have maybe coronary artery disease and you want to diagnose it, they do stress testing, right? So they do stress tests to see how good the perfusion is to the myocardium. So you have them exercise. Well, in certain individuals where they can't exercise for whatever reason, they give them a drug called dipyridamol. And what dipyridamol does is it dilates the vessels going to the myocardium so that you can see the perfusion on the imaging techniques that you're utilizing. But it increases the blood flow through the normal vessels, but not very much through those actual fixed or stenotic vessels. So that's why dipyridamol is also good for stress testing, if you wanted to remember that as well. One of the big things with all these drugs is that some people say, what about knowing the dosage? Dosage is important, but you can always look those things up, and it's important to make sure that you do look those things up so that you don't make a mistake whenever you're giving someone the medications. Obviously, knowing someone who is having some type of acute coronary syndrome, it is important to know that you should give them 325 milligrams of aspirin, have them chew it and then swallow it. But more for your daily prophylaxis, it's more along the lines of like 81 milligrams per day. Clopidogrel, the big thing that you should know dosage-wise of this one is if you are giving it to someone who's going to be going to get a PCI or some type of carotid artery stenting, or they have had a CVA that's been greater than the period of 3 to 4.5 hours, then you can give a loading dose of 300 milligrams, and then from that point on, you give them 75 milligrams every day. But what I want you guys to remember is that these medications are basically designed to be able to prevent from what conditions, or treat acute coronary syndromes, CVAs outside of the range of receiving TPA, people who are going to be getting carotid artery stenting, or they're utilizing this basically as an adjunct to stenting, CAD prophylaxis, preventing them from having another myocardial event. Again, aspirin for giant cell arteritis, which is a particular type of vasculitis. PAD, the good one, cilostazol, and decreases the risk of colorectal cancer significantly. And again, dipyridamol, it's used for specific types of cardiac stress tests to look at myocardial perfusion imaging. All right, so those are the indications of these medications. All right, guys, so let's talk about the last two things here, which is going to be the adverse drug reactions that can happen. Sometimes whenever you're taking these medications, you got to be, you got to watch out for. As a clinician, it's important for us to be able to recognize what is some normal side effects, but what are the things that we don't want to miss. So when you're putting people on these medications, these antiplatelet medications, there is a couple things that we do really have to be aware of and we have to watch out for. So you have to think about these things. One of the big things that you want to watch out for is you're putting some people on antiplatelet medications, antithrombotic medications. You're trying to stop blood clots. So sometimes if maybe you receive too much of you give them too much of the medication, or they have some type of just severe adverse drug reaction where they're a rapid metabolizer of the drug, they can have excessive bleeding. And we want to watch out for that. So what are some of the things that we could see that actually allude us to, oh, we might have them on too much of this medication, or we got to watch out, we got to discontinue this medication. So things like this would be bleeding from orifices or bleeding into the surfaces of tissues. So one of the big ones that you got to watch out for is if someone is bleeding from their nose. What do you call that? Epistaxis, right? So you want to watch out for what's called anterior epistaxis. So that could be one type of indication that's letting you know, ooh, they might be bleeding too much, and I need to discontinue this medication. One is if they're bleeding from their gingiva, from their gums. So what if somebody shows signs of gingival bleeding? So you start seeing bleeding from their gums. Okay, that could be an indication. So if you see gingival bleeding, that could be an indication saying, ooh, they might be on too much of this medication, we got to discontinue. What if you see little pinpoint bleeding, like little dots, little pinpoint hemorrhaging little suckers on the skin? What could that be indicative of? They call this petechiae. So if you see petechiae, or you see very large types of pinpoint hemorrhaging, that could be indicative of some type of purpura. Or maybe they're really large bruising, and that could be ecchymosis. So if you start seeing a lot of bruising on the skin, petechiae, purpura, ecchymoses, that could be indicative. Or if there's blood that's actually coming out through their mouth hole, right? So if someone is actually vomiting up blood. So if they have, if someone is having hematemesis, right? That could be an indication. So someone's vomiting up blood. Or they're having melena, so they're having blood coming out through their stool. Maybe it's a dark type of blood, and that could be indicative of an upper GI bleed. Or maybe it's bright red blood, which is called hematochezia, and that could be indicative of maybe a lower GI bleed. So those are things that we want to watch out for. Okay? Another thing is that sometimes there could be excessive vaginal bleeding or uterine bleeding. So we want to watch out for any type of abnormal vaginal or uterine bleeding. So these are some of the things that we want to be aware of when patients are on these medications. Look for any signs of bleeding. Sometimes you might not have any blood that's visible. So what should you do if someone you think is on this medication, they might be bleeding, they have iron deficiency anemia whenever you take their a CBC? Go ahead and do a hemocult, okay? So check to see if there is any blood inside of the stool as well. Again, so whenever someone's on these medications, do a very good physical exam. Look at their oral cavity, look at their skin, ask if they've had any recent nosebleeds, ask if they've had any dark stools, if they vomited up any blood. Do a hemocult, check a CBC, ask if their periods have been heavy, have they had any bleeding after sex. Anything like that is important to make sure that we look for that stuff. The big thing that I really want you guys to be aware of, and you have to be careful of, whenever you're putting someone on things like particularly Clopidogrel and another one called ticlopidine. That's why they don't use ticlopidine as much anymore, but Clopidogrel you also have to be careful of with this one. It's called TTP. So you have to watch out for what's called TTP. Thrombotic, thrombocytopenic purpura. So what happens in this condition? Basically you have platelets, right? And what these platelets do is they're designed to be able to stick with the von Willebrand factor that's basically stuck in that collagen meshwork. So let's go ahead and draw some von Willebrand factor molecules. What happens is, here's your von Willebrand factors here, these little pink guys, right? Now normally von Willebrand molecules are these little monomers. They're just one little single protein. But what can happen is they can actually start fusing with one another. And this is a normal physiologic process where they can fuse with one another and they can go from a monomer to a multimer. Okay, and you have a specific enzyme, thank goodness, that basically prevents this from happening and breaks these multimers down back into monomers. Okay, And that enzyme is called Adams T13. It's called Adams T13. So this enzyme is designed to be able to stimulate the multimer breakdown into monomers. That's important. But in certain situations, there might be a decrease of Adams T13. What could be an indication of that? What could be a reason? Antiplatelet medications such as Clopidogrel, Clopidine. It could even be conditions like lupus, or sometimes chemotherapy medications like gemcitabine, cyclosporin. Some of those medications could also be reasons why there's a deficiency in this enzyme. If that enzyme can't break down the multimer into monomers, what happens? They just auto-populate. And guess what they do? Guess what loves to stick to von Willebrand factor? Platelets. And so then what do you get? You get this huge platelet mess here. And all these platelets start sticking to these multimers. And what happens then? The platelets start getting consumed, but they start forming lots of clots. So two things happen as a result of this. You get a decrease in platelets. They start getting consumed because you're making tons of clots. So you get an increase in clots because these multimers of von Willebrand factor are binding tons of platelets and you're getting big clots. But you're using so many of the platelets that you have a decrease in platelets. So there's thrombocytopenia along with widespread clotting. This is TTP, and that's what you got to be careful of. So what are some of the signs that if someone's coming in with, you have to make sure that you recognize it and treat them accordingly? If someone's coming in and they have a fever, okay? So if they're febrile, if anybody comes in and they're presenting with a fever, that would be an indication, okay? Maybe it's greater than 100.4 degrees Fahrenheit, right? Or you get a CBC, and on that CBC, it shows signs of hemolytic anemia, okay? Because again, you're also within this process, you're going to start having red blood cells come through this area. So there's also going to be breakdown of your red blood cells, hemolytic anemia. So you'll be able to see that whenever you check, because whenever these red blood cells are busted open, you get an increase in what's called LDH, an enzyme inside of the red blood cell. You get an increase in bilirubin, which is a component of hemoglobin. And there's another enzyme that loves to bind to hemoglobin. And whenever hemoglobin is released out into the blood, this enzyme, once this protein binds to it, and that's called haptoglobin. So the amount of free haptoglobin will go down because it's bound to hemoglobin instead of free, okay? The other thing is you're using up your platelets, so the platelets are going to decrease. So you're gonna have thrombocytopenia. Another thing is that there's going to be damage to the kidneys. So there can be renal insufficiency. If there's kidney damage, the ability to excrete out things like creatinine and a lot of blood urea nitrogen products decreases. So what happens to that? There's an increase in creatinine. There's an increase in the BUN if you take and do a BMP. And on top of that, there's also certain types of neurological damage. So they might start experiencing things like headache, they might have things like confusion, okay? And that's some of the things that we have to watch out for as well, okay? You can remember this through the mnemonic FAT-RN. FAT-RN. So FAT-RN, you remember fever, anemia, thrombocytopenia, renal insufficiency, and neurological damage, okay? When someone has this, what do you treat them with? The best thing to do is to do what's called plasmapheresis, okay? And what plasmapheresis is you're basically taking out all of these different types of structures that are inside of the blood and cleaning the blood, okay? So you're gonna do plasmapheresis. They can also do what's called steroids, corticosteroids. And the reason why is we're trying to reduce the inflammatory response. And sometimes they can use other medications like rituximab. And again, we'll talk about that in another video when we specifically go into it. But for right now, if you notice it, you got to treat it. Plasmapheresis, steroids, those are usually the main treatments. All right, so contraindications to utilizing these medications. There's a very, very important one you got to remember. If a kid comes in, basically they say anything less than 19 years of age, so less than 19 years of age. If a kid comes in, less than 19 years of age, and they have a fever, you never give them aspirin, okay? You never give them aspirin, and you want to make sure that the parents know that as well. The reason why is, and again, the mechanism isn't completely like rock solid, but this is what they think. Inside of your liver, you have mitochondria, right? And the mitochondria are responsible for taking free fatty acids and breaking them down through a process called beta oxidation into what's called acetyl-CoA. And then acetyl-CoA goes through the Krebs cycle, and it generates some molecules like NADH, FADH2, all these little suckers, and that stimulates the electron transport chain to make ATP. Well, what they know is that there's two things. One is when someone takes salicylates, it's actually metabolized by specific enzymes in the actual mitochondria. And their metabolites can actually affect this process of fatty acid oxidation. So here's what I want you to remember. So if someone is actually taking aspirin, all right, gulp, taken absorbed, it has the ability to alter the metabolism of these free fatty acids. So the metabolites of the aspirin has the ability to inhibit the free fatty acid oxidation process, okay? So that means what? Less acetyl-CoA, less NADH, less FADH2s, and less ATP. Well, guess what? If someone is infected, let's say that they have a virus, okay? Let's say here we have a virus. Whenever someone is infected, these viruses have the ability to increase the actual metabolism of these salicylic acid metabolites. So there's going to be more metabolites of aspirin whenever someone is having a viral infection. So this virus has the ability to potentiate and increase the number of salicylic acid metabolites. That means if you have increased salicylic acid metabolites, you have increased inhibition of free fatty acid metabolism, less acetyl-CoA metabolism, less NADHs and less FADH2s, and less ATP. If you don't have ATP within inside of this cell, what happens? All the functions of the cell start to decrease and the cell will start to die. Its ability to perform its functions will decrease. What is one of the big things that the liver does? It filters out different types of toxins. You know, there's a process where you take amino acids and you rip off a specific molecule called ammonia. And ammonia is supposed to go through a process inside of the mitochondria called the urea cycle. Okay? Well, if the liver is failing, are you going to be able to metabolize that ammonia? No. What happens to the ammonia then? It starts to increase in the bloodstream. As ammonia levels increase in the bloodstream, it actually moves its way into the central nervous system and affects cool little cells here called astrocytes. And it actually gets inside of the astrocytes, okay, and binds with a molecule called glutamate and turns into glutamine. And this causes the astrocytes to become osmotically active and pull a lot of water into them. And they start to swell. What can this result in? This can result in encephalopathy. Encephalopathy. Which it will show up as signs as maybe vomiting. Then they can then progress maybe to fatigue. And then maybe they'll progress from there into seizures. And maybe even into a coma. As well as they can have delirium as well. So when someone has a fever, particularly maybe a viral infection, they're less than 19, you give them aspirin, you're going to lead to this liver damage. That liver damage will result in increased ammonia, hyperammonemia, which will result in encephalopathy. So what is the triad? You have a patient who has a febrile illness, liver failure, or liver damage. How will you determine liver damage? What's the markers? Whenever the liver's damaged, it releases AST, ALT, all of these will be increased as well, right? So you'll have signs of liver damage. You'll have vomiting, fatigue, seizures, delirium, coma, signs of encephalopathy, and a patient less than 19 years old with a fever. What do they call this? They call this Rye syndrome. So this is a contraindication. You do not give somebody who is less than 19 with a febrile illness Aspirin. Okay, that's one of the contraindications. Another thing that we have to talk about really briefly here is what are some other reasons why you would not want to give someone some of these antithrombotic agents? What if they already have really low platelets? So what if their platelets are extremely low? Especially one of the big ones is Abciximab. Your GP IIb/IIIa inhibitors, they really can drop down your platelets. So if someone has less than 100,000 platelets, you do not give them GP IIb/IIIa inhibitors. So it can cause thrombocytopenia. So you don't want to give someone these drugs if they are extremely thrombocytopenic, especially like less than 100,000 platelets per millimeter cubed of blood, sorry. Another reason, what if someone has uncontrollable hypertension? So their actual blood pressure, their systolic blood pressure is extremely high. That's one reason. Another reason why is because with high blood pressure, there's risks of tearing through that tunica intima layer. And whenever you do that, what can that cause? That can cause aortic dissections. So then, with this happening, if someone has uncontrolled hypertension and they have aortic dissection, a history of aortic dissection, they're at high risk of bleeding if you give them any of these medications. So be careful if someone has a history of an aortic dissection or they have uncontrollable high blood pressure. Well, that's another reason why you wouldn't want to give this. If they're already bleeding, if someone has maybe a perforated peptic ulcer. So what if they have a perforated peptic ulcer or some type of GI bleed? All right, so this could be a problem if someone is having a GI bleed, whether it be an upper GI bleed or it be a lower GI bleed. Or if someone's having an intracranial bleed. So if someone's having some type of, particularly maybe like a subarachnoid hemorrhage, you don't want to give them that medication. Or if there's some type of trauma. So maybe they were stabbed, or maybe they went under the knife for some type of really intense surgery. That's another indication of where you're not going to want to give this medication. All right, so that should cover all of the things that we should need to know about antiplatelet medications. All right, Ninja Nerds, in this video we talked about antiplatelet medications. I hope it made sense. I hope that you guys did enjoy it. If you guys did, please hit that like button, comment down in the comment section. Please subscribe. Also, as a reminder, please go check out the Great Courses Plus. Again, you can go down in the description box, or it's thegreatcoursesplus.com/ninjanerdscience. They have a lot to offer, and it can definitely further your knowledge on multiple different topics. So go check that out. As always, Ninja Nerds, we love you, and until next time.